Hello and welcome to this overview of evidence-informed public health, epidemiology and epidemiological study design. In this session, we're going to discuss the hierarchy of evidence and evidence-informed public health. We're going to define what epidemiology is and its role in public health. We're going to describe a brief history of epidemiology and the key characteristics of epidemiological research. And we're going to provide a quick overview of the main epidemiological study designs and how they relate to each other. So what are the hierarchy of evidence and evidence-informed public health? Well, different types of study designs have different strengths and weaknesses. This means we can create a hierarchy or classification of quality of the different study designs. So, randomized controlled trials and cohort studies are judged to be better than case control and cross-sectional studies. This is because we can control bias and confounding better in these studies. So quality is really about the quality of the study to provide accurate results. The better quality the study, the more rigorous the study, the more likely the findings of the study are likely to be true, all else being equal. But it's important to recognize that different study designs are good for different types of research. Each one has value. We can't do randomized control trials for every kind of research question. We do need a range of different types of study designs. So the hierarchy of evidence is, as its name suggests, a hierarchy going from the bottom to the top. And it's normally shown as a pyramid or a triangle like this. And as you can see at the bottom, the weakest things, and they're not really studies, but they are case reports, opinion papers, and letters. And so case reports, opinion papers, and letters are the weakest type of study design. Case reports in this context are single event studies, so a study of an event or a group of people, and then above that you can see here are animal studies. So animal studies here, animal trials and in vitro studies. In vitro studies are cell studies where you get cells that are grown in the lab and then you do tests and experiments on those cells. Animal trials are where you trial, normally it's drugs or other types of chemicals that you need to test for safety, and they're normally trialed on dogs, rabbits and monkeys, being the closest animals to humans in terms of their physiology. However, many of these animal trials aren't that good because dogs, rabbits and monkeys are not that close to us as humans, and so sometimes for these animals the drugs or the chemicals that we're testing on them are fine for them but are still toxic and harmful to humans. So we do have to do human studies as well, and human studies are the best. And the four types of human studies that we're really interested in epidemiology are cross-sectional studies, case control studies, cohort studies, and randomized controlled trials. Now there is a fifth kind of study, which is a special type of cross-sectional study, and these are longitudinal before and after, also called pre and post-test cross-sectional studies, where a cross-sectional study is done before an intervention is undertaken, and then another cross-sectional study is done after the intervention is completed. Essentially they are cross-sectional studies, except you're doing them twice. You're doing them one beforehand, before the intervention, before the action, before you give people some kind of education, for example in public health, on diet or physical activity, and then you test afterwards using a cross-sectional study design to see if that education has changed their attitudes, beliefs, perspectives and knowledge, and whether they're going to change their behavior and be more healthier. So randomized controlled trials are essentially, out of these four, the strongest type of study, and in later sessions we will discuss why that is the case. I just want to mention briefly the two things right at the top of the pyramid, at the apex. Meta-analyses and systematic reviews. And systematic reviews and meta-analyses are not individual studies. Meta-analyses are studies where researchers gather original data from existing studies. So they go, for example, to 5 research teams who have already done, for example, 5 randomized controlled trials, and they ask those research teams for their original data, and they collect that data based on the fact that these randomized controlled trials are similar to each other. Yeah, that's really important. You can't just mix different trials or different studies together, but you can collect and collate and analyze similar studies looking at similar research aims, research objectives, using similar endpoints, using similar types of populations. So you get similar studies which have the similar research aims, and then you collect that original data and then you analyze that original data. And of course, if you're looking at 5 studies instead of 1 study, generally data from 5 studies is likely to be more accurate, better, and give more robust, more higher quality findings. So that's what meta-analyses are. And systematic reviews, well, systematic reviews are essentially a special type of literature review, and here researchers find all the studies undertaken on a specific topic or public health intervention, and then they collect those and review the studies in the published literature, and then analyze the findings and see what the findings are telling us. So for example, if there are 10 cohort studies, for example, looking at whether populations with high fat diets are more likely to have cardiovascular disease and heart attacks, then one study might say that. But if we find that 10 studies are saying that, then that obviously makes the finding much stronger. However, often what tends to happen in epidemiology is that out of the 10 studies, 5 may say that yes, high fat diets can lead to having more heart attacks, and 2 may find no significant results, and they don't find that result, and 3 may turn out to say that actually those people with high fat diets do not get more heart attacks than people on lower fat diets. So this is where literature reviews and systematic reviews can help, because by collecting the findings from 10 cohort studies, we get a better idea of how strong the evidence is. That's why meta-analyses and systematic reviews are on the top, because what they do is they collect the information from many studies and then present the findings from those studies, either by reanalyzing them, in the case of meta-analyses, reanalyzing all the original data and collecting them as if it's a big, massive study. So imagine a randomized controlled trial that has 100 people in it, and one has 500 people in it and one has 1,000 people in it. Well, if you collect those 3 randomized controlled trials, and because they're similar, they've got similar aims, they've got similar types of people taking part in them, then it's better obviously to analyze a study that has 1,600 people, 100 plus 500 plus 1,000, than it is to have a study with just 1,000 people. So that's the value of meta-analysis. It's likely to give more robust results. And systematic reviews, again, just a reminder, there you're just collecting the published findings and then you're presenting them and seeing whether they're pointing in the same direction. The more studies that say yes, high fat diets does seem to lead to an increased risk of heart disease and heart attacks, the more likely we can then use that for public health actions. And if the results do not point in the same direction, or the findings are mixed, then we can realize that actually we're not so clear about whether high fat diets, for example, definitely lead to an increase in heart attacks. Now, the things that are not scientific evidence, I'm sure you've realized, are general purpose things that you see, Facebook, YouTube, newspaper articles. Yeah, these are not studies and they're generally not seen as scientific evidence. They may be useful, but often they're not that useful. Yes, unless you do systematic study and analysis, that is not likely to be high quality evidence. But there are other types of evidence, like community evidence, the experiences and knowledge of communities and about where they live, that can be helpful. That while it's not scientific evidence, it is useful evidence that we can use to inform public health policies, public health actions, public health interventions. So there are two types of things. Yeah, I've talked about evidence-informed public health, but there was an earlier idea called evidence-based public health, and that is still there in medicine, where we talk about evidence-based medicine. But for public health now, we've moved to a newer phrasing, which is evidence-informed public health, and we'll talk about why that is different in a moment. So evidence-based public health can be defined as a public health endeavour in which there is an informed, explicit and judicious use of evidence that has been derived from any of a variety of science and social science research and evaluation methods. The definition highlights two aspects of evidence-based public health: the use of a particular type of evidence to inform public health decisions, and an emphasis on clear reasoning in the process of appraising and interpreting that evidence. And so you can see the highlighted words and phrases. So it is an endeavour, it's an activity of public health, yeah, in which there is informed, explicit and judicious use of evidence. So this is really important, and that evidence is often from epidemiology in the case of public health, but it can be, as it says in the fourth line, from a variety of science and social science research and evaluation. It's informed because the use of evidence, you do need some expertise, you do need some understanding of scientific evidence and its strengths and weaknesses, to be able to use that evidence wisely. And you have to be explicit in that you present all the findings that you have. You don't cherry pick, you don't show one part of the material that you have, you show all of it and show that how you reached that result in terms of the evidence that you have identified. And it's also about judicious use. What does that mean? There is a judgment element. You have to be judicious because it's not always clear cut what the evidence is telling us. So there is an element of interpretation. You have to be judicious in what you think, how much you can use it and apply it to different contexts, different populations, different countries, different situations. So in terms of the two parts that it specifically highlights in this definition, it is the use of particular types of evidence, and it's really about scientific evidence, whether that's social science, public health, toxicological, scientific evidence or medical knowledge. It's a particular type of evidence. And then the second part is there has to be clear reasoning, and that links to this notion of being explicit in your use of evidence, that you have to be clear in how you analysed, you appraised, you summarised, you interpreted the evidence from the studies. So let's look at this kind of more modern approach to evidence and public health that's called evidence-informed public health. It's the process of distilling and disseminating the best available evidence from research, context and experience, and using that evidence to inform and improve public health practice and policy. Put simply, it means finding, using and sharing what works in public health. So here, this is a really nice definition. We start with distilling. Distilling is essentially synthesizing. It's looking at finding patterns and connections between the evidence, finding themes. So you're distilling all the huge amount of evidence potentially on a topic and bringing it down to a really small summary of key points. That's what distilling means. And disseminating is essentially, there's no point doing evidence-informed public health. There's no point analyzing evidence and reviewing it and distilling it if you're not going to share it and disseminate it to policymakers, politicians, communities, so we can act on that evidence. We try and use the best available evidence from scientific research, but also from the context and experiences that we are looking at. So, for example, we will talk to professionals, we will talk to communities and bring that experience in. We'll also look at the evidence around context, because research when applied to different contexts may not work. If for example, the simplest example is research undertaken in England on a health promotion project where we were looking at HIV and stigma, the findings of that, the intervention used for that study may not work somewhere like Brazil or Rio or Ghana or Korea in Southeast Asia. The reason being they're different contexts. There's different social, cultural, economic aspects, and therefore these country contexts, these city contexts are different from the UK, and therefore you may not get the same results using that intervention that was successful in the UK. So context is important. Understanding the context within which that research was done and understanding the context within which you want to apply that research is really important. So what are the brief steps in evidence-informed public health? Well, there's essentially 7 steps. You define the question that you're interested in, you search for information and evidence on that question, you then appraise the evidence, you synthesize it, you adapt it to your local context or national context, you then implement policies or projects or programs based on that evidence, and then you evaluate your projects, your policies and your plans to see if you have achieved your hoped for public health objectives. Please look at this website. It's really good. It's the National Centre for Methods and Tools in Canada. It's part of Health Canada. And what's the 4 sources of evidence then that go into forming evidence-informed public health? Public health expertise is involved in bringing these 4 sources of evidence together and synthesizing them. So first is obviously scientific evidence, scientific research in purple here, and then second it's local community health issues and their local context. What is the situation locally? What are the existing health issues? What are the existing social issues in that community that may impact on the intervention, the policy, the program, the project that you're interested in? What public health resources do we have here? What kind of people, time, money, skills, partnerships do we have? And then lastly, community and political preferences and actions. What are the cultural aspects that it will determine whether the research that you're interested in, the intervention that the research is saying we should undertake, will fit, will suit, will be accepted by communities and by politicians. So this is the 4 key elements that public health brings together in order to inform decision making around health and well-being at local and national and international levels. So let's now move on to a quick introduction to epidemiology. Please watch this video. The link is there on Blackboard in the week session, so please have a watch of that. Let's go on to the definition and role of epidemiology. I really like this diagram. It shows you the connections or the issues and the aspects that epidemiology is interested in. Yes, we are interested in the person here at the centre and the things that are affecting them, but we're also interested in the social aspects, the social environment, the built environment, family, economics, government, culture. And we're also interested in land, climate, water, air, the physical aspects of our environment. We're also interested in ecosystems and how ecosystems connect together. And lastly, we're interested in, the whole worldwide universe galaxy within which we're a part of. Now, of course, often we just focus on the person and populations, but it's important to remember that all of these, the epidemiology connects and health and well-being connects to a wide range of issues and factors, and hence a lot of things in epidemiology are interconnected, and we are trying to often look at one aspect of an issue by essentially hoping that the rest of the issues remain the same and do not affect our research. So we do miss a lot out in our research. We do miss a lot of the interaction effects that might happen. Okay, so what's the definition of epidemiology? So Porter's definition here is a good one. It's the study of the occurrence and distribution of health-related states or events in specified populations, including the study of the determinants influencing such states and the application of this knowledge to the control of health problems. So if we bring these keywords out, you can see it talks about occurrence and distribution. So we want to find out where things occur, where diseases, where exposures, air pollution, for example, or heart disease and heart attacks in terms of occurrences, where are they occurring, where are they being distributed. So these two aspects are essentially about describing. So epidemiology is at one level about describing things, describing where things occur, when they occur, and then later on how they occur. And then the determinants element is about understanding, explaining and quantifying the factors that influence our health and well-being. And lastly, control is about how we can affect change, how we can intervene in the process to prevent disease and promote health. So, in more simpler terms, epidemiologists ask the following things: who has what disease, what exposure, when, where and why? What causes exposures lead to what health effects, outcomes in a given population? How are causes and health effects distributed over time and place? What interventions can influence causes so that they reduce or increase health effects? For what populations and in what contexts? And I think the last one is really important, remember, as well as the third one. So if we look at the third one, it's not just about causes and health effects and exposures and other how other factors influence people. It's also about how they influence people over time and how they influence people in different places. So when we're talking about interventions to reduce or negative health problems and enhance positive health issues, we're often interested in how does this intervention work, for what populations and in what kind of social, economic, environmental context. So the role of epidemiology in public health is about measuring and explaining disease patterns and trends. Understand the causes or cause of diseases, describe the natural history, how diseases progress, how they start, how you get infected, how you might, over time get heart disease because of your unhealthy diet or lack of physical activity. So a natural history of how the disease works and how does the disease affects people, and the effects of preventative interventions and treatments on diseases. Epidemiology also informs disease control and prevention programs, and it also informs public health and healthcare services planning and evaluation. So you can think of classical epidemiology and 21st century epidemiology. Classical or modern epidemiology focused on communicable disease outbreak control and surveillance. There was a lot of monitoring of prevalence and incidence trends in the social, demographic and geographic distribution of diseases and conditions, identifying and quantifying disease risk factors, and evaluating surgical, medical and other public health treatments. But since then, we kind of moved over. Yes, we still do communicable disease outbreak control and surveillance. We still do some modelling of disease risk and developmental outcomes. But we also now evaluate health and social care and public health interventions and programs within and across communities. We also look at evaluating health service systems, undertaking health needs assessments, looking at injury and accident prevention, and also disseminating critical appraisal skills to a wider audience. So now let's look at this triad, agent, host, environments, because basically epidemiology is looking at this triad. Health can be thought of as a state of equilibrium between these three factors. The agent which causes the illness, for example, you could also call it the exposure. The host is the person, us, who are affected by it, and the environment is the wider environment within which you find the agent. So this is a nice model that brings in another factor, the vector. So let's look at this not in the example that's given, but in another example of malaria. So the host is us, the person, the vector is the malaria mosquito, and the agent is Plasmodium falciparum, the parasite that resides within malaria mosquitoes, Anopheles, for example. And the environment is a wider environment within which you find the Plasmodium parasite and the malaria mosquitoes. So you can see here, this is a non-communicable disease example. So here the host is us, our genetic susceptibility, our income, our resilience, and then the agent is, for example, cigarettes, filtered cigarettes or other types of cigarettes. And the vector is the manufacturers, the distributors, the vendors of the cigarettes. And the environment is the wider policy environment, the society we live in terms of, do we have an indoor air policy? Do we have a ban on smoking in public places? Do you have a ban on advertising? And of course, pressure from peers, from friends to undertake that behavior without smoking or not smoking. It could be either way. Pressure to do both. So you can see here, this is a kind of nice visual diagram of the factors that influence whether people smoke or not. It's not just about them, it's also about the manufacturers and distributors, and it's also about the environment in which they live and work, and what kind of policies are in place, whether there's taxation to make so that cigarettes are expensive. And what's nice about this is you can intervene at various levels. You can here take action between host and agent, between host and vector, or host, vector and agent, or vector and the environment, or environment and the host. So this gives you opportunities. These lines are opportunities where you can break the pyramid or triangle that's created by this agent host environment diagram, and prevent the host, us, being affected by cigarettes or malaria. So in terms of looking at this is a kind of another triad that you can think about in terms of descriptive epidemiology and what it tries to do, and that is, we're interested in the place, the person, and the time. For most things in epidemiology, these are the three key things we're very interested in. So what are the key historical points in epidemiological history? So the origins of epidemiology is from the Greek word epidemos, epi, upon, demos, the people, and logos, study. So Hippocrates, the father of medicine, 2,400 years ago, first used the word epidemion for diseases that visit a community, compared to endemion, diseases that live in a community. First used in 1902 as part of the title of a Spanish book, Epidemiologia Española, and the first use of epidemiology was in the 1950s with the creation of the London Epidemiological Society. So we've talked about Hippocrates. So Hippocrates was one of the earliest authors, medics around, and you can see his volume 7. He wrote various chapters in these volumes, epidemics 2 and 4 to 7. But the key kind of historical development really happened in the 1800s, and particularly with John Snow, often known as the father of modern epidemiology. His classic work was on the mode of communication of cholera. Cholera was a feared disease, a bacterial infection often caused by ingesting contaminated water. There have been several cholera pandemics since the first in 1817. It was the first global disease. Of the three pandemics of Asiatic cholera, in 1817 to 23, 1826 to 37, and 1846 to 63, two reached the British Isles. And you can see how people were affected by this little quote from this book about the history of London's most colourful neighbourhood, Soho. Whenever cholera broke out, which it did 4 times between 1831 and 1854, nothing whatsoever was done to contain it, and it rampaged through the industrial cities, leaving tens of thousands dead in its wake. And I imagine that to what we're facing at the moment with the COVID. We did not let it run through the community, though there were some things people did say at the beginning that maybe herd immunity and letting it happen in the community might be a good thing. So this is how John Snow did it. He mapped people who had been infected and where they lived, and also then how close they were to the Broad Street pump, which he was wondering whether it was water that was the key factor, and doing this visual diagram showed him that yes, indeed, one of the pumps on Broad Street was likely to be the key source of contamination with cholera bacteria. Now, one of the things to remember is in the past, and it's very easy for us to laugh at people from the past, but in the past, people have had various theories. There's been the miasma theory, which is essentially that bad smells emanate from the ground, and that's what makes us sick. Spontaneous generation was another theory, essentially saying that basically we don't know why diseases happen; they just happen, magically. Miraculously, there's no cause, it just happens in the blood. And lastly, of course, the one we know that's more true, that's the truth here, is the germ theory. The fact that there are small organisms called bacteria and viruses that can get into our bodies and cause damage and make us ill. The second key development was in the 1950s, and before the Second World War the focus was on communicable diseases, but after the Second World War, after 1945 onwards, and in the 50s and the 60s onwards, the focus shifted to non-communicable diseases. In this era, the key epidemiological study designs were developed. The key approaches that we use now were developed then in the 1950s, and it was the start of the analytical or risk factor epidemiology era. So some of the key studies from this time are the case control study by Doll and Hill in 1950, proving that smoking causes lung cancer or increases the risk of lung cancer. A cohort study called the Framing Our Heart study, which looked at how diet had an impact on cardiovascular disease and heart attacks. And a randomized control trial from 1948, which was the streptomycin treatment of tuberculosis, again showing how streptomycin was effective in treating TB. And this is a quote from Doll, and it shows why epidemiology is so important and why it resonates with the general public. Because we watch the news, we see these things in the news, and we do listen to them. The results of epidemiological research are often of immediate concern to the individual in the way in which he conducts his daily life, and to society in the way its activities are controlled. And then moving on, we talk about the third phase of development, which is the end and re-emergence of communicable diseases. In the 1980s, there was thought that we had conquered communicable diseases. However, HIV, SARS, swine flu, avian flu, Ebola, and Zika all made us realize, those in high-income countries, that these are global health hazards and can affect anyone around the world. And so these are the kinds of issues, aspects that epidemiology grapples with. So what are the key epidemiological approaches and methods? Well, first of all, please watch this video. It will be Blackboard page. Let's just move on to just talk about things that we will talk about in more detail later, but it's important to know. Causation, or working out what causes something, whether one thing causes something else, is a complicated business. It's not so easy as people might think to say one thing causes another. We need good evidence from research, from scientific studies, but even then there can be multiple causes and multiple effects. Multiple causes of a disease or health problem and multiple effects of an exposure. So often it's very difficult to disentangle what is causing what and how the thing is actually occurring. The second complexity is, as we've just mentioned previously, is that in the past there has been a decline in infectious diseases and an increase in non-communicable diseases, chronic diseases like diabetes, obesity, cardiovascular disease, respiratory illnesses, and so on, cancers. And generally what's happened is, as birth rate and death rates go down and the population and wealth stabilizes, so there's a population growth slows down and people are generally well off, then we find that infectious diseases go down and non-communicable diseases go up. But now we're finding, particularly in low and middle income countries, that actually no, infectious diseases are high, and also non-communicable chronic diseases like heart disease and cancer are also high. Not in all communities in low and middle income countries, but in many communities. And this is a kind of another example here, global burden of disease, well worth having a look at. What are the different causes of death around the world, and why are there such different causes and different rates? Because if they're similar, then they shouldn't be actually, they should all be the same colour. But you can see here that in some parts of the world, particularly kind of Eastern Europe and Russia, and one part of Africa, I'm not sure what country that is, that all causes in 2017, deaths per 100,000. You can see here deaths in Eastern Europe, and I think this looks like Ukraine here, it was very high compared to other parts of the world. And the question we have to ask is why? The other thing to notice is that in the past we thought infectious diseases only caused communicable diseases, but guess what? They don't. They can also cause, bacteria and viruses can also cause non-communicable diseases. Helicobacter pylori bacteria cause peptic ulcer and gastric cancer. HPV, human papillomavirus, also increases the risk of cervical cancer, and bacterial infections and heart disease, chlamydia pneumoniae and Pseudomonas aeruginosa, are both linked to an increased risk of heart disease. So it's not a clear-cut relationship between communicable disease on one side and non-communicable on the other. Epidemiology is interested in understanding how an individual or group of individuals with a disease or health state of interest, whether that's an exposure to green space or an exposure to air pollution, relates to the population from which they come from. So we generally don't study individuals, but we do collect data from individuals, and then we get these group of individuals and we collect data on them about their exposures and their activities and a wide range of other socioeconomic and other factors and variables. And then we hope that our understanding of these people here, these group of participants in our research, will tell us something about the population as a whole. And the problem is, of course, that populations have many more connections in them than our participants do in our study. So our participants who come to be part of our study are not as interconnected as the population that we're interested in, and therefore we're only getting a representation of the true population. No study can be exactly like the population of people that they come from. There is always something different about them. So, in lay terminology, we talk about causes and effects, or a cause and an effect. But in epidemiology, we don't do that because we're more cautious. We're not sure that the exposure is really creating the outcome, the cause. Air pollution really is leading to respiratory health issues. We're more cautious, and we talk about exposures, the thing that people are exposed to, air pollution, high fat in their diets, smoking a cigarette, and whether that leads to an outcome, whether that's a cancer, whether that's some kind of chronic disease, whether that's an infection, or whether that's an effect on their mental health and well-being. And remember, exposures can be positive. So for example, we can have positive exposures to green space, or positive exposures to having friends and family who are supportive, and that leading to positive health outcomes, both physical health outcomes, reduced stress, leading to improved physical health, as well as obviously improved mental health and well-being. So this relationship between exposure and outcome is called an association, a link or relationship. It's not cause. It's not called a cause. We don't say the exposure causes an outcome. We say the exposure is associated with an outcome. It's only when we have a lot of strong evidence do we then talk about causal relationships and exposures causing outcomes. So an association is judged to be causal where the strength of evidence for the association is judged to be strong. For example, looking at the Bradford-Hill criteria and finding that many of the aspects of what Bradford-Hill identified have been met. There is disagreement about how useful the Bradford-Hill criteria are, but I think it's a good starting point for those coming to epidemiology for the first time. I think the Bradford-Hill criteria are a really useful guide to thinking about what makes strong evidence and how we need a range of different criteria before we can decide whether an exposure really is causing an outcome. So now let's move on to the general approach, the general strategy, the general steps for epidemiological research. Firstly, you define a hypothesis. Often in research study papers, you'll see they'll talk about the aim of the research or the aim and the objectives of the research. And that really comes from them having a hypothesis. So they have a hypothesis saying A causes B, or we think A affects B, whether that's poverty and a lack of a job leads to poor well-being. That's our hypothesis, and then the aim of our research might be to test that. And so we create an aim saying we're going to do an intervention and we're going to see if we give people a job, whether that then leads to an improvement in their health and well-being, particularly their mental health and well-being. We then, from that hypothesis, and it's from that question that we then choose a study design. So the question determines what kind of design of study should we have. So if it was an intervention, the best type of study design would be a randomized controlled trial. But we can't always do that. So then you'll see often in the literature, you do a before and after repeated longitudinal cross-sectional study, where you do a cross-sectional survey before the intervention is run. You then do the intervention, and then you do another cross-sectional survey with questionnaires or interviews with people afterwards to find out if the intervention has changed anything or not. And these designs are not as good as randomized controlled trials, where you have two groups of people, one who get the intervention and the other who don't. We'll talk about that in future sessions. So the study question, and this is a really important point, the study question decides what kind of study design you want to go for. From that hypothesis and that study design, you then decide what kind of population you need to have to achieve that aim in terms of to answering that question, answering that hypothesis. You then define the exposure and define the outcomes, and then you will decide how you will measure them. What equipment, whether that's a blood pressure monitor, whether you're going to take someone's pulse, or whether you're going to use some kind of questionnaire in terms of like a mental health and well-being questionnaire, or you're going to use some other type blood sampling, or whether you're going to measure their height or use a pedometer, for example, if you're measuring physical activity. So you need to define the exposure very carefully, you need to define the outcome very carefully, and then you need to decide how you're going to measure these two things to make sure that you're measuring them as accurately as possible. Often we use questionnaires, and they're not always the best way to capture information, but they're often the easiest ways to capture information. Then you look at minimizing bias and confounding, and as I said before, we will discuss that in future sessions. Then we will analyze the information that we've gathered, we've collected from our participants in the research project, and then we will interpret the analysis. Usually we do statistical analysis, we interpret what the statistics are telling us, and all of these things, from defining the hypothesis, choosing the study design, choosing the study population, defining exposures and outcomes and how they will be measured, minimizing bias and confounding, analyzing the information gathered, and interpreting the results of the study depends on the place you're doing it, the resources in terms of skilled people and money, and of course the time you have, because these three factors also affect what kind of study design you are likely to do. Because sometimes while you may have a choice of a number of study designs, the type of place, whether it's very remote or very easily accessible, the resources in terms of money and skilled people at hand to help you with the research, and the time you have to do the research will affect what kind of study design you will do, what kind of exposures and outcomes you will measure, and maybe even the kinds of bias and confounding that you can minimize. So we're now near the end of this session, just looking at an overview of the different types of studies. So there's two broad types of studies that epidemiology undertakes: observational studies and interventional studies. So there's many more observational studies, as you can see. You can see here the blue. There's many more observational studies. There's 4 listed here, and different types of those 4 core studies. And there's really only one type of intervention study. They can be done on 2 different types of data. So let's look at observational studies. So observational studies can be done on individuals, i.e. you're collecting information from individuals, and you can also do it for groups, and that means you're collecting information at the group level. So what do we mean by collecting information at the group level? Collecting information at the group level is about, for example, having information about a city. So for example, London, you can have information about the average air pollution in London. Now, the average air pollution in London is not a good indicator for what an individual's air pollution is like, exposure is likely to be, because we know that in central London, and anybody living in central London is likely to have a much higher level of exposure above the average for London, and people living in outer London are likely to have below average exposures to air pollution. So data from groups, group level data, whether that's at council, borough council, district level, whether that's at regional level like London level, or whether that's a national level. So you can get data from groups, and where you have data from group, you can then do a descriptive study where you just describe the information, the statistics that you have gathered, or you can do an analysis where you link it and say, one type of thing, one exposure is causing one kind of outcome. So for example, I mentioned air pollution, so you could take average air pollution levels in London, average rates of mortality from cardiovascular disease as your outcome, and then you could go and find another city, Manchester, Glasgow, maybe New York, Seoul in Korea, Rio in Brazil, Cairo in Egypt, and then you look at the different air pollution levels and see whether, when you map those and analyze those relationships, whether you find, for example, and you do find, because these studies have been done, where studies with high levels of pollution tend to have higher levels of cardiovascular related deaths. Those types of studies are called ecological studies. And then the studies where you have information at the individual level, so you've asked individuals through a questionnaire or some kind of direct access to information from them, such as blood pressure or height, weight, or case notes from their doctor, providing information on their illness, or providing information about their background health. Then that kind of individual level data can again be discussed descriptively, just explaining what that data is about. That would be, for example, number of people with diabetes living in London. So you could do a descriptive study just talking about how many people have diabetes based on GP or primary care doctors. Or you can do an analytic study, and the 3 types of analytical studies you can do are an analytical cross-sectional study. So you can do a descriptive cross-sectional study, hence you can see this line there. So you can do a descriptive study, but you can do a descriptive cross-sectional study, and you can also do an analytical cross-sectional study where you look at exposures and outcomes and you try and create a relationship between the two. Cohort studies and case control studies are also the 2 main analytical observational study design types, and we will talk about them, as I said, later. And there are other types of study designs that are similar to the ones that we're talking about here. For example, a nested case control study, so where the case control study is nested within a cohort study. But for now, let's just stick to the main ones that we're going to talk about. So we're going to talk about ecological studies, we're going to talk about cross-sectional studies, we're going to talk about cohort studies, and we're going to talk about case control studies. And lastly, we come to intervention studies. And here, the exposures are deliberately allocated. So we give one thing to one group of people, individuals, and then we don't give something to another group of individuals. And so this can be broken down into groups and individuals. So for example, let's say we have 10 villages or 10 towns. So what we can do is we can trial at community level. We can, in the 5 towns, we can give an exposure. For example, we can try a policy where we are giving food vouchers, for example, to unemployed people and people on low incomes. And in another 5 towns and villages that are similar to the first 5 towns and villages, we won't give anything. They will just be as they are. And then between the two, the 5 towns and villages who did get the food vouchers, where unemployed people and people on benefits got food vouchers, compared to the 5 towns and villages where they didn't get it, we then analyse them at the community level, at the group level, because we're doing it across the whole town. We're not doing it at the individual level. We're not gathering individual level data. And then the individual level data is often the trials or the study design types that you know about, which is medical trials where one group of people get the drug or get the treatment and the other group don't get the new treatment, and we see whether the people on the new treatment do better than the people who don't get the treatment. So often we can again do that. For example, we could do a health promotion educational activity, and we can get a group of people, we can split them into 2 groups, and one group we can give the health education to, and the other group we just give a leaflet to, and then we follow them up over time and see whether there's differences between the 2 groups and whether the education has had an impact and had led to some changes in behavior or changes in knowledge or changes in attitudes and beliefs that hopefully over time will lead to changes in health behavior and then changes in or improvements and positive changes in health and well-being. There's a range of places where we can get data and statistics. You've got routine sources like registration of births and deaths, death certificates, obviously, special disease registries. There's often cancer registries that collect data on people with cancers and when they die and how they die. We also have disease notification for communicable diseases. And there's also, as I said previously, primary care records. You can also have national censuses, which happen every 10 years. That can also be a good source of data. And we can have special surveys, demographic, health, lifestyle surveys, household surveys that are done regularly, often every year or every 2 years. And we can also obviously do specific studies to collect data that, again, might have been collected for a different purpose, but we may be able to use it for our research because it may have data that is useful to us as well and will help to answer our research question. So just moving to the kind of end of this session, just saying there are a range of current and future challenges to epidemiology. One of the issues is about using the huge information knowledge about disease generated from genetic and molecular research. How can we use some of that to benefit health and well-being? It's not so clear-cut at the moment. There is a lot of genetic and molecular research, but it's not clear how we can use it in public health. There is also a move from a focus on disease to a focus on health and increasingly well-being, because really we want to keep people healthy. We don't really need to focus on what happens when people get the disease or preventing disease. We also want to think about improving health and well-being. We need to understand better and more holistically the way all these factors, environmental, social, economic, cultural, interact with each other and impact on health and well-being. One of the things, as I said earlier, that we don't see all the networks and connections between populations. Yeah, we get a group of people who at random, we are participants, and that's great, but actually they don't have those connections, they don't have those social connections. So we don't really have the lived experience of what happens to people, and we don't really analyze those factors. Often those factors are taken out the study because we call them the kind of confounding factors that might change what we're looking at. But actually we do need to try and understand the confounding factors because they may be important facts that can help us to improve health and well-being. Then there's this issue, as I said before, about the double burden of disease. How do we work with communities and with countries where, communicable disease and non-communicable disease are both critical things? And lastly, we look at these interventions, but now we increasingly have very complex interventions. How do we evaluate these using epidemiological approaches? How can we look at effectively evaluate these complex interventions, understand what kinds of impacts they are having at different levels? Well, I hope you enjoyed this. If you have any questions on this, please write them down and we can discuss them in the next session, the apply session that we'll be having. I hope you found this a useful and interesting session. I look forward to speaking with you later. We will do some exercises in the apply session based on this lecture. Yes, look forward to seeing you next time. Thank you.